Rolling. Renegades. Andre and I had this big idea.
Growing.
I had to have the people who didn't believe in me.
Between one day and the next, everything changed.
Nurses know how to solve shit.
Renegades.
Welcome to the RNegade podcast, a revolutionary approach to continuing education for nurses who don't just do what they're told. We're shining a light on the innovators, the pioneers, the renegades, who are blowing up the boxes that the rest of the world is still trying to think outside of. In this podcast episode, we introduce Sarah Lorenzini, a seasoned leader and educator in emergency and rapid response nursing, devoted mother of 5, and host of the Rapid Response RN podcast, a welcome addition to the RNegade PodClass Library. Sarah shares her passion for caring for others throughout her journey from the bedside to the broadcast booth. She discusses her diverse experiences in emergency and intensive care nursing, emphasizing the importance of recognizing early signs of decreased cardiac output in patients. Sarah highlights the need for nurses to trust their instincts and connect with patients on a human level. She also talks about her decision to start a podcast to educate and support fellow nurses, blending her love for teaching with her clinical expertise. This episode underscores Sarah's dedication to making a positive impact on nurses around the globe, the nursing profession, and healthcare in general through the global reach of the Rapid Response RN podcast. Please enjoy Sarah Lorenzini.
There's this funny meme. Let me see if it's 3 nurses and they're like all look like they're like 110 and they're drinking and smoking and they're like retiring early at the age of 55 or something like that. but you don't look like you have a 26-year-old for sure. Oh man.
I'm 40 now. I turned 40 this year.
Congratulations, you made it. I'm going to start with my impression of you because, you know, we've had some interaction. We never did a podcast like this before. Antra would have loved this. She absolutely adored you. Like she just light up. And I think it's because when we did Kickstart My Heart series, your focus was it's like you're such a powerhouse of knowledge, but it's delivered in this very maternal, inspirational, like an inspirational speaker kind of a package. Have you always been like that?
Yeah, I'd say so. Like I was always the kid that was like, who can I care for? Are there babies around that their mother needs help? Like who is hurt? Who is hurting? Like my heart, when I walk in a room, I can just like scan and very quickly see who needs support, attention, inspiration, encouragement. And I just am very drawn to those people. And I've always been that way. 9-year-old Sarah got a fanny pack for her birthday. And I always wore it. And it always had Band-Aids in it, just in case someone needed a Band-Aid. Like I always have carried like Tylenol and Motrin and allergy medicine and feminine products, just in case someone around me might need something and I can support them. So yeah, I've always been kind of wired that way. My mom passed when I was a kid, and I had to kind of like take on the maternal role with my younger sister. And so it's just always been somewhat innate in me to want to like elevate the people around me and support in however I can. It brings me great joy. It's not just like, I got to go help this person. I'm like excited for the opportunity to help and be a support. Like a good day for me is a day that I feel like I've made a difference.
Yeah.
And so that's when I reflect on my days and like, okay, even though the patient didn't live, I got to be a part of that family's journey and like support them through that. I feel like I made a difference in that way. Even though I didn't save a life, I was at the bedside of someone who was passing. And to me, that's a good day. So
it is.
Yes, I've always been that way.
It is. It's sacred work. Those, you know, it's rewarding to know what to do in an emergency situation, have that confidence and go, yay, a life was saved. But it is just as rewarding to bathe a patient with their daughter in the last moments of their life, or, you know, hold a hand as the family says goodbye. Like that's, I'm sitting here behind a desk. It's good work. I feel like I'm doing good work, but I really, really miss that part of nursing. Did you always know that nursing was going to be your vocation?
No, and I blame that on the media because the way they portrayed nurses in movies just was not an accurate representation of how badass we are.
Yeah.
I thought I wanted to be a doctor because in the movies, the doctors are like giving the medicine and saving the lives and talking to the patients, and like they do all of it in the movies. And so in high school, I actually volunteered in the hospital, hoping to like see some doctors in action and kind of like get a feel for it, build my resume, you know. And I remembered like 2 weeks in, thinking to myself, I haven't seen many doctors. Like, where are they? And so I asked in my, naivete, I asked the charge nurse, like, hey, so when do the doctors come and like take care of the sick people and like give them their medicine and like teach them about their diagnosis? And she just bust out laughing. And she was very tender, but she's like, sweetheart, the nurses do that. The nurses are the ones that give the medicine and give the education and walk the patients through this journey. We change the dressings. We do all of that. The doctors, they already came and left before you got here for your shift. I was like, what do you mean came and left? She's like, yeah, they already did their rounds. They're done. I was like, it was mind blowing. But from that point, I remember kind of like reflecting, oh, well, maybe if what I want to do is help people, be with people who are suffering, support people through, whatever hardship they're facing with their health, then maybe I do want to be a nurse. That was a difficult thing to wrap my head around. So I had told everyone I'm going to be a doctor when I grow up.
Yeah.
But then to make that transition of, well, actually, what I want to do is the work of the nurse. I want to be the one to give the medication to make me feel better. I want to be the one that has time to sit with them and walk with them through this journey. I don't want to just have 30 patients that I'm rounding on once a day. I want to like be with people. And then after I had that realization, well, then I'm watching the nurses and realizing, oh my gosh, these nurses, they know their stuff. Like they're just like spouting out all the information about the medications they're giving. They're assessing. They use stethoscopes too. Like I was like,
remember the show me your stethoscope movement?
Yes, I do. I had some strong feelings about that one, but yes, for sure. Many posts of me wearing my stethoscope and like show me your stethoscope. Anyways, so yes, I have always known I wanted to care for the sick. I did not know I wanted to be a nurse until I got to see nurses in action and realize, okay, that's how I'm wired. That's probably the best fit for me. So even still, a lot of doctors will, I think they're trying to compliment me and they'll say like, oh, you could have been a doctor or you could be a doctor. You would have made a great doctor. And I just say, thank you so much. I know you're trying to pay me a compliment, but I intentionally became a nurse because I prefer the role of the nurse for the way that I'm wired. But thank you. I recognize you're trying to compliment my intelligence. That's very kind, but I don't want to be a doctor. I want to be a nurse. And they're like, but that's just how I am. That's what I'm wired to do.
Well, that's also education, isn't it?
Mm-hmm.
What was the trajectory of your career path? Like you decided you wanted to be a nurse and then what happened?
Okay. So that was like 9th grade, I guess. So then my high school actually had like a CNA training program. So I did that. And then I started college in the 11th grade, finished all my prereqs for nursing, and I started nursing school at 17. I graduated nursing school at 19 with my associate's degree. And I was a brand new grad in the emergency room at 19 years old, which is so like my friends work at Chick-fil-A and I'm working in the ER on night shift.
What part of what part of the US did you start?
I'm in Florida.
Okay.
Yeah. So 19 years old. I was so young and
how did you get that gig?
And I still am, but well, I was a CNA, like I said. So while in nursing school, I got a job in the ER as a CNA. Again, not thinking I wanted to be an ER nurse. I just thought this will be the best training for me as a nursing student to see ER patients and like all the different types of emergencies, all the different types of diagnoses. I want to see all of it. So I got the job there just more of a learning thing, not that I actually wanted to be an ER nurse. And I discovered I just love it. I love being with patients and families in crisis. And I'm actually pretty darn good at it. And I can see the difference that I'm making whenever I walk in the room and explain the process and kind of calm people down. I just found that I really thrived in that, surprisingly. And so, yeah, they hired me as a brand new grad right out of nursing school. This was 20 years ago when they didn't really hire new grads in the ER. You basically had to like kind of prove yourself in med surg first before you're an ER nurse. But I'd already worked there as a tech. So they're like, all right, we'll give you a chance. There's no ER educator or ER training programs. You're just going to have to like figure it out. But yeah, welcome. You got this, Sarah. And yeah, that's how I became an ER nurse at 19 years old. and did ER nursing for a while, discovered that I really liked teaching ER nursing. So went back for my master's degree in nursing education. In grad school, all of my professors were like, if you want to be a nurse educator, you should probably branch out of the ER a little bit and try something else. To which I was like, well, what else is there? I love ER nursing so much, but I'm also quite a nerd, like quite a nerd. And CVICU to me has the most nerdiness going on. All of like the gadgets and the pathophysiology behind the heart has always been fascinating to me. So I went and worked in the CVICU, did that for 3 years. And then I was asked to be on the rapid response team. And that was like the perfect mix of all the things, right? Rapid response nurses are very much like ER nurses, but very much like ICU nurses. And I got to teach along the way too. And then I finally got that master's degree in nursing education. It took me a long time because I was single mom for a bit. Like it was just a very challenging season of my life. And I was like, woo, I'm gonna take a break. I'm gonna be a nursing professor. So I was a nursing professor. I left like, well, I left, I was still PRN, but nursing professor for a whopping 1 year. And it was great as far as mom life goes. The schedule's really good. But then I missed all of the emergencies, you know, and being a bedside nurse. And so the nurse actually that was my charge nurse when I was a new grad had become the director of the ER, like a local ER. And he asked me to come be the ER educator. So I was like, okay, this is the perfect mix, right? I get to still be at the bedside, but teaching nursing, using my master's degree. The schedule's Monday through Friday, which is great for my family. I have 5 kids. So I did that for a while. Also loved that. I love teaching nursing. I love supporting nurses as, you know, in their journey. And then COVID hit. I was like, man, as much as I love teaching nurses, I really want to be in the trenches with these nurses. I'm tired of teaching like donning and doffing of PPE. And oh my gosh, I just wanted to do the work. And so the hospital that I work at now, 5 years ago, didn't have a dedicated rapid response team. If a rapid response was called, the ICU charge nurse would leave the ICU and go respond to the emergency on the floor, which had been fine until COVID. And like every ICU patient is sicker than ever. We have all these ECMO patients now. Everyone's on the ventilator. And then the med-surg patients are sicker than ever. We've got like heated high flow on the med-surg floors. It was a crazy time. And so I went to leadership and said, I would like to start a rapid response team here, a dedicated team. That's all we do is respond to emergencies and try to prevent them. And they said, well, the short version of the story is they said yes after much convincing. And then so I started that team. That was 4 years ago. And now our team has a Beacon Award. Like we are an awesome rapid response team. So nationally recognized by the AACN for our level of excellence. So yeah, that's my story. Oh yeah, and the podcast, I should probably add that. So like a couple months into being a rapid response
this is the great thing about interviewing a podcaster. Like I don't have to answer. You know what I'm going to ask next. So
yeah. So then I'm doing my rapid response live, working full time as a rapid response nurse, and then I missed being an educator. And I would try to educate right after the emergency. I'm like, all right, let's debrief. Let's talk about it. But then the next, code's going off and I'm running away. I just didn't feel like I had the time to like educate, which is what I love to do. And I was venting to my husband, like, did I make the right decision? I miss being an educator, blah, blah, blah. He's like, why don't you start a podcast, Sarah? You love podcasts. You are constantly listening to nursing podcasts. Why don't you just start your own? To which I laughed because if everyone that knows me knows I am the least tech savvy person. Like it's laughable how bad I am with technology.
I'll take you up on that. I'll take you on that one.
You think you're worse?
Tech inept.
So I kind of like the idea kind of like rumbled on my head for a while. Like, could I start a podcast? I mean, I have the experience. I have the certifications. I have the degree. I don't have the tech skills, but I can learn. I can do hard things. So basically me and YouTube University, we figured out how to audio record and how to set everything up and how to publish a podcast. It was a whole other learning curve that I had never delved into. And I started my podcast. It was just me and a $15 microphone. And I literally sat in my closet because according to my research, it has the best acoustics. All of the jackets and the soft fabrics around you help the audio sound good. So I recorded a couple episodes in my closet. And my original thought was this is just going to be something that I can give to nurses. So hey, I'm highlighting some of the great the saves of our hospital, some of the great nurses and how they advocated for patients, using the stories from rapid response cases that I went to then break down the pathophysiology and the pharmacology and the nurse's role. I thought it would just be a way to still get my scratch my educator itch a little bit and still give back to the profession in a way. And it just surprised me how much it blew up. like on my podcast platform, I could see where nurses are listening from on the globe. I'm like, how is a nurse in Australia finding my podcast? How are 13 nurses from Qatar listening to my podcast? Like, it was so cool to me to think that I can support nurses across the globe from my closet. Like, this is so cool. And so that is the generation of rapid response RN podcast. It started out just me wanting to give back to the profession, still be able to educate nurses because I do love teaching. And it turned into this like, wow, I have a great opportunity to support nurses I could have never supported before because of, physical proximity. And now I get to like help them on their journey. And then I started getting emails from people like, thank you so much for episode 10. I had the exact patient and then I knew what to do. I recognized they were declining. I spoke up and advocated. I understood the pathophysiology. I knew how to respond to it. Thank you for that episode. It saved a life. And I'm like, oh, this is the best thing ever. I love recording podcasts in my closet. And so as you can see the studio behind me now. We turned that closet. We like tore down some walls and put 2 closets together to make a little mini recording studio. So now in my house, I have a little podcast recording studio. And I actually do this part-time. So I work 2 12-hour shifts at the hospital. And then I spend a couple days a week working on the podcast and creating nursing education. So yeah.
I love that. I love that you're still working and have always have fresh stories. And that's one of the things I love about your podcast is not only do you use real cases and then give the background, the pathophysiology and what happened and what could happen and how to recognize this, but you always I don't even want to say mistakes. You also use perhaps to some of the greatest podcasts are when stuff went wrong. Like and my last shift I ever worked in a hospital, I was clinical coordinator on night shift in an ICU that did bypass surgeries. We were really short staffed, as usual. So my 1-to-1 fresh heart was actually, I had another not so fresh heart, but I was also preceptor. We had lots of new, like fresh off orientation nurses. So I was also kind of a resource nurse for them. I was the IV nurse. Pharmacy left at midnight, so we had to mix our own drugs. And all of this was going on. And it was like the third 12-hour shift I'd worked and I was exhausted. And it wasn't until about that 4 a.m. slump, somebody asked me to give her patient, she had to go, I don't know, it was like she had to go off the unit. She asked me to give her 6 o'clocks. And I was so tired and I was just getting careless because I was so tired and everybody was asking me questions and I had my own fresh heart. So, I gave a beta blocker at 4 when it should have been given at 6. Now, med error, just wrong time, 2 hours early, not that big, but it could have been anything. It could have been potassium. Because the thing that scared me so much about it was I wasn't there. I was just going through the motions. I was not present, checking the right patient, right time, right, blah. And I called the supervisor I saw what I did. Blood pressure didn't change, a blip. Called the supervisor to tell her what happened and said, you got to write this up. She's like, Karen, look at what you're doing. I'm like, you have to write this up. I don't care if I lose my job. I don't think I'm going to lose my job. But if this isn't written up as a med error, things aren't going to change. Like she argued with me. I wrote myself up and went into my nurse manager and I told her what happened. And she's like, if something happened and somebody saw fit for you to, we can't lose you. And I'm like, you just did. I quit. And that was the last shift because it was, and I've used that to teach so many, like just that anecdote and in so many of your podcasts, this is what went wrong. This is what could have been done. This is what next time I would look for or recognize. This is how you can, and it's such a great tool when we say we're human. And that's the thing that it's, how you come across in your podcast is so relatable and so human, but also at the same time, so badass that no wonder you have a huge audience. And I don't want to even say well-deserved because it's like you just followed the breadcrumbs and like followed the effervescence and like, yeah, I could start. I like to teach. Like, there's the effervescence. I like to do this. Oh, here's a way for me to do this. And of course, it's being shared around the world. And of course, it's saving lives. And you are like the exact package. I'm not blowing smoke up your ass. This is just like my genuine. I hope it's
Thank
coming
you.
across as genuine.
It does, yeah.
Because and I'm so happy that you're part of the RNegade library now, because we're learning all the time and we don't get credit for it. And the stuff that's most valuable to learn is the stuff that we learn from other nurses.
Yeah, for sure. I mean, I think the most impressionable lessons that I have come across were other nurses sharing their stories or hindsight lessons that I learned from experiences. And so I'm like, how can I package those into learning opportunities? I don't want to just read from a textbook on a podcast. I don't want to just regurgitate, uptodate.com. I want to say like, okay, this one nurse, let me tell you what she did. I'm going to interview her on my podcast so you can hear how she advocated for the patient. Let me tell you about this one time that I was wrong and turns out the patient had this going on. We all missed it. Don't miss this, right? Those are the lessons that I want to share with people, not just like rote pathophys. And, the other thing too, I think that the pathophys is like sexy and like emergencies, like, oh yeah, rapid response RN, that's a cool podcast. Yes, I try to make it cool and interesting, exciting, but my hope is that in this cool packaging of like emergencies that people love to hear those stories, that I can sneak in some slivers of the heart of nursing. I did not become a nurse because I wanted to sling up an effort and do CPR. I became a nurse because I want to be with people who are suffering and walk them towards health or walk them on their journey to whatever's next after this life. I didn't want to just do the cool stuff. I wanted to be with people. And so I try to sneak in every episode little glimpses of like how you can still connect with patients, even whenever it's chaotic, how you can advocate for that like human connection, not just treat the patient like a machine, how you can use your voice to speak up and make sure the patient gets the best care. Like those are like the heart of nursing things I try to like sneak in there. But yeah, no one comes to a podcast for like, I want some inspiration for how to be resilient as a nurse. People love the like badass nurse stories, but what they are secretly are getting are little glimpses of how Sarah is at the bedside, because that's the kind of stuff that I feel like wasn't necessarily taught to me in nursing school. I had to come across that by watching other people model it well and watching people model, which I do not want to do, and kind of taking lessons from both of those. So that is my other, like my secret initiative with the podcast, is to also teach not just the science of nursing, but the heart of nursing too.
Yeah, it's like the most painful moments or the biggest regrets I've had in my nursing career aren't because of something I did wrong or something that happened that was wrong. It's those rides home wondering if there's something more I could have done.
Mm-hmm. Yeah. Hindsight's our best teacher, right?
Yeah.
Like I'm always reviewing cases afterwards. I'll go to my colleagues and be like, hey, how did that code go? Anything you noticed to me I could have done better? Did I miss something? Or ask the doctor, like, how did you think things went down? Did I wait too long to advocate for the patient or to speak up? Anything I could have, I'm always asking, anything I could have done differently? And I have learned so many things I could have done differently that way, rather than just always trying to prove that I know what I'm doing and I know how to do this. I'd rather just say, like, teach me. Like, if I could do something differently, better, faster, like, I want to get better as a nurse for my patient's sake. But yeah, hindsight is the best teacher. I've learned a lot of things reflecting on my behavior, reflecting on my clinical decisions, on my silent and often heavy ride home.
Yeah. Can you share, like, was there one that sticks out that something happened? It doesn't even have to, it could be outside of nursing too. But something that really contributes to who you are now as a nurse, as a person, something that happened in your life that made everything different from one day to the next. Is there anything that stands out to you?
I mean, there's not like one particular thing, but I've had so many encounters with patients that have just changed my perspective on like humanity, in the ER, you kind of see the worst in people. Like, people don't come in on their best behavior in the ER. They have lots of addiction and violence. And I mean, there's just so much evil in the world that ends up with injuries and ends up with illness. And you see like the worst of that sometimes in the ER. But some of even those patients that people would say are like the hardest to deal with, the ones that are like, I don't want to take care of that patient, give them to Sarah. Sarah can handle it. I've been able to connect with even those people and kind of like see past the behavior and see through to like the human soul I'm caring for, and just see a whole different side of somebody come out. You know, someone who is very aggressive or rude or even inappropriate. Whenever you can like let them see that you see their humanity and you see their potential and you see their hurting and their suffering, I've seen people totally transform their behavior. And so that was very impactful for me as even a new nurse learning. You don't have to just be like, now listen here, you're in the ER, sit down and be quiet, and I'm the nurse and you're the patient. Like that's a very common ER approach towards care. Like the power dynamic, the power struggle, I've never bought into that. One, I'm 5'3" and 110 pounds. I'm really not the best person to like lord my power over a patient. But I have been able to connect with people who are maybe difficult to connect with. And to me, that's like it brings great joy. You know, someone who's like, I'm gonna climb this mountain, or I'm gonna like, I don't know, jump out of this airplane. Like, this is a big challenge that I want to overcome. I feel that sort of like, I'm up for the challenge when it comes to, say, a challenging patient. Like, okay, how can I connect with them? How can I utilize my skills, my compassion, my training to find a way to like form a connection with this human that still needs care and compassion?
So how do you do that? Is that a skill you've had to cultivate, or were you like, did you just cheat because you were given that gift?
No, it's definitely a skill that needs to be cultivated.
How do you take like in all that's a skill that's so makes a great nurse in any specialty, not to take things personally, to maintain compassion as well as have impact through your knowledge and skill, and, you know, positively impact the health and the recovery while maintaining compassion with a potential asshole, you know, who's under all that stuff. What have you cultivated within yourself that allows you to do that? And is it something that that nurses can also develop if they don't naturally have it? Because my guess is the way you've described 9-year-old Sarah with a fanny pack full of Band-Aids is kind of, you were born with it.
Yes, I'm sure there is some like, you know, nature. Like my grandmother's a nurturer. My mom was very compassionate. Like there's like a nature aspect, but there's also like, I have chosen to learn from difficulty and from my environment, and I've chosen to let it make me more tender rather than more jaded. So like, here's a small example. When I was 17, I was in a car accident and I was trauma alerted to the ER. And my grandmother, who's a nurse and an absolute saint, also a pastor's wife, like sweetest lady ever, I saw a whole other side of her as she was being almost like aggressive with the staff, trying to advocate for me. And I was like, oh my gosh, I've never seen my grandma be mean. I've never seen her, like, she was just not herself. And I remember at 17 thinking to myself, oh, because she's not at her best self right now. She's afraid, you know, she's worried for her granddaughter. Like she's worried about the outcome. Like I was just hit by a car. Like, of course she's not going to be her best self. And I carried that with me when I became an ER nurse, when families are like just freaking out and losing their shit. I'm like, okay, wait, but they might not always be like this. Think about my grandma, like that kind of stuff. It just helped me reflect and like reframe how I saw people. But also too, I tap into a resource much greater than myself. There's been many times where I, on my own, do not have the capacity to show up with compassion because this person is just annoying the crap out of me. They are rude. They are hateful. I have a really hard time with people who are racist. I have a really hard time being compassionate towards them. And so oftentimes I just have to like go to the bathroom and say a prayer and be like, God, please help me see this person the way you see them. They are someone's child. They are someone's spouse. They are someone's father, mother. Like, please help me have compassion to care for them, even despite, you know, their behavior. But that doesn't mean I'm like Pollyanna. I'm like just letting people abuse me or talk down to me or like only see the good in people. Oh, I am fully aware of the assholes that come in the ER. I'm fully aware. And I absolutely stand up for myself, but I do it in a way that is still like compassionate with the firmness. That makes sense. So I don't want people to think like, oh, Sarah's just like, oh, come on, I'll just give you love. No, if you're going to be a jerk, I will definitely call you out for your behavior, but in a way that's not going to be, what's the word? It's from my compassion for you that I will take a stand and tell you how you're acting, not
Well,
because of my annoyance. If that makes any sense.
it makes total sense. And in a nutshell, it sounds like what you're talking about is integrity, because integrity is not taking that personally. Like, it's truth, right? It's the truth. This person is a human being. This person is suffering, and I'm going to look at them as a human being. And if I have difficulty, seek prayer or whatever your thing is. But integrity is also having the courage to be disliked, and not leaving yourself to please somebody else. But it works. There's a dark and a light to that, right? That is not only what allows you to have compassion with difficult patients, but it's also what allows you to, you only put up with what you think you deserve. And when you stick up for yourself, you're also saying, I don't deserve that treatment, and neither do you.
Yeah. And I've told hundreds of patients, hey, that's not how we talk to each other. Like, that's not going to work with me. I can't allow you to speak with me that way. I can't allow you to speak to my coworker that way. I'm going to come back and we'll try that again. But this interaction we're doing right now, I'm not having it. It's inappropriate. So I don't want people to think that I'm just like this sweet little, like, oh, sweet little Sarah. Oh no, I absolutely stand up for myself. They made me the charge nurse in our ER when I was 20 years old. 20.
Oh my gosh.
And it's not because I was so clinically competent, let me tell you. It was just because they know that I have the ability. I think maybe integrity was there too, that I would be fair, that I would be organized, that I would be a clear communicator, and that I wouldn't put up with abuse. And so part of being a charge nurse is advocating for your team. And I laughed out thinking about it. There'd be some angry person like, I want to speak to who's in charge. Like, sure, let me get Sarah for you. And I beam up on there with my 5'3" self and my like Daisy scrub top. Like, I'm Sarah, what's going on? I try to do my big girl voice if I could. Yeah. So definitely I've learned a lot about myself being an ER nurse. You know, you just see like so many aspects of yourself get a chance to come out. I've always had the ability to like connect with all kinds of people. And so I feel like if someone were to just watch me on my shift, they would think I have like multiple personalities, because I walk into one room and I'm like, hello, my name is Sarah. I'm going to be your nurse. How are you feeling? What's going on today? And then literally right next door, all right, listen here. This is not how this is going down. I'm going to sit back in the bed. We cannot continue to behave this way. It is not safe. And then the next room over, I'm like making jokes and laughing. And then the next room over, I'm praying with the patient. Like, so many aspects of Sarah have to come out so I can connect with all types of people from whatever they're experiencing, whether it's like good news or bad news, or they've just been arrested, or like I've had to tap into multiple sides of myself so I can be the best nurse for all types of patients. But
the maternal badass. You're describing
the
behavior of a mom.
Yeah.
Like, and who loves their kids and corrects their kids more aggressively than a mother, and who nurtures, like it sounds like that's what you bring into the maternal badass nurse. Yeah. Since you've started the podcast and the feedback you've gotten, what is it that nurses are most seeking to know? What do you think that's lacking out there in nursing education that they're getting from your podcast?
I love that question, because that's really what drove me to do it in the first place. I think nursing school prepares you to pass the NCLEX. So like you learn how to answer the multiple choice question. But what I hope to teach nurses is when you walk into a patient's room, what do you actually do with that knowledge? No one's asking you multiple questions. Would you like to do A, check the airway, B, check, like, no one does that. So learning how to apply that head knowledge into real clinical scenarios. And I try to really walk that through as I'm describing. And then I approach the patient, and then I assess for this. And then I said this, and then this was their response. And here's how I responded to that. And then we discovered this. So just helping nurses kind of like see themselves through the eyes of the case that I just experienced. I don't think there's a good place for that in nursing school. Like it's hard to really make that happen, especially because you can't orchestrate real emergencies to happen in a clinical setting. I mean, you can do simulation,
right?
But simulation is way less stressful than the actual patient who's declining. And so I hope that I can like relay what I'm feeling, what I'm seeing, what I'm experiencing, what I'm processing, and kind of teach nurses to process it the same way. I did not have this skill set when I was a new grad. All the things that I'm teaching, all the critical thinking, all of like the years of seeing patient after patient after patient with this presentation has led me to the ability to recognize, oh, that's the signs and symptoms of a AAA. Oh, that's the signs and symptoms of a patient who's going to septic shock. Oh, this is a patient who's herniating. Like, I've seen it enough that now I can critically think to that conclusion. But I want to like help people take a shortcut from just having the head knowledge of like, this is what the diagnostic criteria are, or this is Cushing's triad on the test, but to actually like see it evolve in a real patient, I feel like is what nurses are hoping to gain from the podcast. And that's what I'm hoping to deliver as well.
Oh, for sure. Like, I wish you were king of the world and could change the way that, it needs to change. Like, even I graduated University of Michigan, 1996. I mean, even back then, it was like $100 and some $1,000 nursing school education. I got my bachelor's. I went like this on a map of the Southwest because I only wanted to be an ER nurse or an ICU nurse. Like, I became a nurse because my mom told me to, but the way I was going to make it fit me was I wanted people to envision me walking toward them in slow motion in a flight suit with an Aerosmith song playing in the background. Like, that was what was going to make nursing, palatable for me. So there was a nursing shortage in the Southwest. So I just pointed to a map, Las Cruces, New Mexico, packed my car, lied my way into an interview, got an ICU job. The night before I started, there were 2 Canadian nurses who had been there for 3 months before me, also new grads. And we went out for a beer, and I did not understand the language they were speaking. I just graduated nursing school, and I did not know, because it was a CV ICU. Yeah. It was like the large, Memorial Hospital was the largest hospital in southern New Mexico. So they did heart bypasses, and I'm like, did you guys learn this in nursing school? I felt like I don't belong here.
We didn't go over that.
I don't speak this language. They're like, we didn't either. 3 months. In 3 months, I learned to be an ICU nurse and recover hearts. Yeah. And nothing that I learned in nursing school had anything to do with that. Maybe it was like learning how to learning where to go for research. If you were king of the world, what would you do to change nursing education in the associate degree programs, a bachelor's degree, so that nurses could come out more prepared to hit the ground running? Or do you think it's not necessary?
So I go back and forth with this, like, do we need to make nursing programs longer to provide more education, or would that deter people from entering the profession in the first place? And we need easier entrance into the profession. I haven't fully decided on that, but I do think there's a lot of fluff we could skip over and get a little bit more meat into the nursing education. I remember, like, when I became a nurse professor, they said, okay, here's your lectures you're teaching. You're teaching an hour on hand washing. You're going to do an hour on sleep. I'm teaching an hour on sleep. We're going to give you the heart failure lecture series. I was like, yes. Stroke. Yes. Like, I can do those. But the professor who taught the sleep lecture, like the year prior to me, she gave me her notes and she's like, Sarah, this is the most boring lecture. I'm so sorry you have to teach it. I almost fell asleep teaching it last time. It's that bad. And I was like, then why are we teaching this? Like, how much do you possibly have to know about sleep to be a bedside nurse? Can we please like give a 15-minute summary of sleep and then move on to the stuff they really have to know? So yes, I would overhaul the stuff that maybe could be like condensed down and focus on what you actually have to know, which I'm sure nursing schools think they've already done that, but at least the one that I was teaching at had some opportunity there. And then the whole death by PowerPoint has got to go. Like, not everybody learns that way. I personally need to be immersed in some sort of scenario to grasp on. And I know that we can't always have simulation. We can't always be in clinicals. But one thing that I did, not for the sleep lecture, but for the heart failure lecture, for the stroke lecture, is I did the whole lecture as an evolving case study. So I videotaped myself giving report as night shift, giving report on a patient to day shift. And then I talked about heart failure and how this patient is declining. And then a rapid response is called. So then I take myself with a different outfit, different scrubs on, and give a report to the rapid response nurse. My patient's declining. Here's their SATs. Here's their vital signs. And then we talked about heart failure from that perspective. And then I took a video of myself as the rapid response nurse giving a report to the CVICU nurse, as the patient now is on vasopressors and requiring a balloon pump. And then I took a video of myself give them report as the CVIC or day shift nurse, give them report to the night shift nurse. So the whole spectrum of the patient came in, Lasix, ACE inhibitors, like the basics, to like, okay, now they're in a full-blown cardiogenic shock. So trying to like help nurses see not just the random like nugget of information to pass the test, but like these are humans that we get to care for. This is the course of their care. Here's what to look for. Here's what, if they're declining, here's how we can turn them around. I feel like just getting the bigger picture is what's missing. Everything's just so fragmented in nursing school. And I know that's a hard shift to make because it takes more work. It took me a lot more work to prepare that presentation, to have to record myself 5 different times with a script that I had built and the whole case study. It took a lot more work than just like cut and pasting information from the internet into a PowerPoint slide. But those students were like, all right, give me heart failure.
Ready to go.
Because it makes so much sense because of that patient, his name was Mr. Hart. Because of Mr. Hart's case, I'm ready to care for him. So I don't know, if I could change all of nursing school, I think that would be it. Maybe cut out the fluff, add in a little bit more intentional, like big picture thinking, force nurses to do critical thinking, not just bullet point. Like, here's the scenario. What are your options? What are you thinking? What's the worst case scenario? What if this happened? Like helping to kind of not just answer the question of the test, but to think like a nurse would be what I would want to do.
That is brilliant from start to finish. And that's what you bring into your podcast too. I mean, it's not the visual, but I wish we could hire you a production company to like, turn, if you have any more closets in your house, maybe we could turn those into like an ICU unit.
Oh my gosh, that would be so fun, just to write scenarios and make videos that teach nurses like how to do the role. That would be awesome. But yeah, it takes a lot of money, lots of time. So maybe one day. I'm
going to start a GoFundMe or something, because I think that's what we need to do with you. You really are well suited to that. And that's where are you going from here? Like, do you see rapid response RN evolving into other things?
Long term, it's hard to say. Right now, I have the podcast and I also have Rapid Response Academy, which is like this hybrid thing that I made up that I had never heard of before, but it's working so far. So podcast is free. I have 128 free episodes nurses can listen to on the go, learn stuff. But for nurses that want a little more, that want not just like more pathophysiology and pharmacology, but like more coaching and support, I made this online community where it is both. Every week I go live and I teach and I provide mentorship and answer questions, and nurses support each other. So like last week we talked about oncology emergencies. I am not an oncology nurse, so I did my best to teach it, but there was an oncology nurse in the group and she was able to be like, oh, and don't forget this. And I had this one patient that had this one time and everyone's like, sweet, like let's pick her brain. And then nurses can like post questions they had or scenarios they faced, or how would you handle this situation with your coworker? And it's this whole online forum of nurses like responding and supporting each other, giving advice, asking questions. It's all the things that I wish I had as a new grad. I didn't have anyone to like do that with. The nurses I worked with were not that nurturing, except for Bonnie. She was my hero. But just to have that community of support and also a place to go ask your questions. Like, how many times have you wanted to know something and you Google it and you're like, that is not the answer. That's definitely not the answer. Or like, I'm not finding the exact answer to what I'm looking for. Even with ChatGPT, I still struggle with that. But if I had a community of 100 nurses that work all over the country in all different specialties, that could just pop out and be like, hey, have you guys ever seen this before? How does your hospital handle this? Or what would you do? I love there's an opportunity for that. So
it's like curbside consults for nurses.
Yeah, it's very much like that, actually. And it has like a mobile app, so you can like do it from your work when you're at the hospital.
I'm joining this.
It's pretty awesome. So I started Rapid Response Academy. It's still new. We've been doing it for about a year now. And so that I hope to grow more and like figure out more ways to support nurses. Again, it's all new. So like, how can I integrate AI? How can I, just provide nurses what they need? So I'm still kind of learning how to do that. I've been given lately a lot more opportunity to speak from a public stage, and that's been really exciting. As much as I love teaching in Rapid Response Academy, it's still like a digital interaction, almost like a Zoom call, Yeah. And I love being face-to-face with an audience and get to speak to people. So in the coming year, I have multiple speaking opportunities booked, and I look forward to doing those. But I don't know what's next. I mean,
that answers the question. That's a lot. That's next, especially with 5 kids and
right.
yeah.
So I think what I would really love to make, and again, this is, I don't know when I'm gonna have time to do this.
No, imagine if.
I want to make a rapid response training course. So Rapid Response Academy is just like how to handle emergencies, just in general. You don't have to be a rapid response nurse. You could work oncology, you could work labor delivery. These emergencies will come to you and you have to be prepared how to handle them, right? But specifically rapid response nursing, it is a very small niche in nursing. So I don't know how financially lucrative this type of training is going to be because there's not many dedicated rapid response nurses out there. But I feel like there's no training for me. I became a rapid response nurse. They're like, all right, go figure out how to do it. And there's so many skills that I learned as far as like team leadership and how to facilitate a code, not just the clinical stuff, but like the leadership side that again took me years to figure out through trial and error, that I would love to just teach courses on that too. So I'd love to figure out how to create a rapid response specific training course. Maybe like a certification.
I must disagree with the small niche. Yes, rapid response nurses is a small niche, but as evidenced by the amount of listeners and followers you have of your podcast, I mean, nobody's, there's going to be a select few that actually get to rise to the level of becoming a rapid response nurse, but anything that they learn in that course makes it makes the med surg nurse a rapid response nurse. It's not going to it's not like taking a water soluble vitamin and peeing out what you don't need. I mean, it's just it's going to stick and make nurses better in general. And I'd love to see how I can help you with that. I mean,
thank you. I mean, I would love to do it. For me, the biggest limitation is just time. Yes. If I had no kids and no job at the hospital, I could just crank out a course. But I still love being at the bedside. So I'm still there 2 days a week. And I also kind of love my kids. So I'm present for them. They have sports and play practice and like all the stuff that's in their life. I don't want to miss out on those things for the sake of creating this course. So for me, it's just going to be waiting for time to open up when I have time to actually put my head to the laptop and knock this course out. It's all up here. It's just transferring up here into a digital course is going to be the challenge, but I would love to do. I would enjoy the process of making it. And I would love to have it offered to nurses because there's nothing out there to train rapid response nurses.
Yeah. I think you need somebody to, just because you have all of the knowledge in your head with the case studies you remember, I'm sure you have a quick recall. It's like you need somebody to just pull the information out of you and you could just I've seen you go before. I would like to close with 2 things. Number one, in your experience, because you're teachers, I know there's not just one, but the ones that are top of mind, what are the 2 most important things in your rapid response experience? What knowledge or clinical knowledge or skill is most important for them to cultivate? And then what from the heart of nursing is most important for them to cultivate?
So I think the most important clinical concept to grasp is the signs and symptoms of decreased cardiac output, because every patient can express those when they go into shock. So recognizing these are the signs and symptoms that my patient is crashing. Heart rate's high, blood pressure's low, skin is cold to touch, they're diaphoretic, they're decreased mental status, tachypnea. Being able to recognize that the second you walk in the room is so important. I see so many nurses that are like, their vital signs were fine. I called the doctor and the vital signs were fine. So he said it's fine. But the nurse gut says, no, it's not fine. And so when nurses are able to be like, oh, it's not fine because I touched their skin and they're clearly shunting their cold extremities and warm core, because look at their work of breathing. They're breathing 40 plus times a minute, not just 14 or 16 like everyone writes down. They actually take the time to count that respiratory rate. When nurses can say, this is not how they usually mentate. This is not how they usually breathe. This is not how their eyes usually look. They're kind of glazed over. Recognizing those little symptoms, I feel like is the most important. So I harp on that a lot whenever I have students, is you need to recognize signs of decline. Don't just look at numbers on a monitor. Here's what you're looking for when you assess your patient.
So what would your ABCs be? I'm kind of changing my question a little bit. I remember when I was a new grad and working in the ER and a bus full of nuns that just got just crashed. And it's like that panic rises, how you talk about your body is preparing you to save a life, the benevolent adrenaline rush you get, and then it can turn into anxiety where you're not going to be much use for the patient if you let yourself get into that anxious state. So I would always remember ABCs back when ACLS and BLS was ABCs. Now it's like BAC, right? It's not even
CAB.
CAB. But I go, okay, ABCs, look at the airway breathing, and it would just kind of ground me. And then if there was something wrong with one of those, then you discover why. And you're kind of like being able to recognize decreased cardiac output, and then going like, what are the top 3 things if nurse is in a panic, you're going into a room, you're looking for signs and symptoms of decreased cardiac output, and then what do you do to discover, like the first thing you discover where the source is? What's the root cause of that?
Right. Okay, so ABCs are still king. We still have to make sure we have an airway and circulation intact. That's still king. But when I approach a patient, in probably 15 seconds, I can know how stable they are without ever taking vital signs. So I walk up, I say, hi there. My name is Sarah. I'm the rapid response nurse. How are you? And it looks like I'm just being really kind, introduce myself. I'm actually wanting to see their neuro status. Do they look right at me? Are they glazed off? Are they not responding? Are they moaning? I'm gathering so much data in just my introduction. And then I physically touch the patient. I put my hand on them and I say, tell me what's going on. Or I'll say, like, I'm here to take care of you if they didn't respond. And I physically touch them. I want to feel, how cold is their skin? Is it clammy? What color is it, right? I'm gathering data about perfusion. And it looks so compassionate, and your audience can't hear this or see this, but I will gently put my hand on their wrist, like I'm just comforting them. And I'll say, I'm going to take really good care of you today. Or there's going to be lots of people in the room, or I say something and I'm actually feeling their radial pulse. And I want to know, I'm not actually counting the number. I'm just getting a quick feel for, is it really fast or is it really slow? Is it really strong or is it really thready? And very quickly I can know they are tachycardic or bradycardic. They are hypertensive or normotensive or probably hypotensive. I'm gathering so much data. And while I'm looking at them, watching their responses, I'm also checking their chest rise and fall. And I'm looking at, like, how much are they working to get that breath in? Are they breathing real fast? Are they not taking enough breaths? It takes me all of 10 seconds to say, hi, I'm Sarah. I'm going to be the nurse taking care of you. How are you feeling? See their neuro response, touch their skin, feel their pulse, watch their chest rise and fall. 15 seconds, 20 seconds, and I know this patient's about to crash, or I have some time to do some more assessments. Now I can get out my stethoscope. Now I can get my pen light out. But if at any point in that initial assessment of neurostatus, pulse quality, skin, chest rise and fall, work breathing, if at any point I see something that's like life-threatening, I will stop. I'm not busting out a stethoscope. I'm not getting an ABG. I'm not getting the pen light. I'm just saying, oh, they're not taking enough breaths. Clearly, I have to breathe for them. Oh, I don't feel a radial pulse. Okay, we got to fix this blood pressure, right? Oh, they aren't responding at all. Can they protect their airway? Do we have to intubate? Like, I can quickly ascertain this person's crashing, or I have some time. So I like to teach this to new nurses. Like, I know you learned to listen to all 4 quadrants of the abdomen and to the lung sounds front and back side and the different tones of the heart with the front of the stethoscope and the back. Like, there's just so much you can do.
Yeah.
You should not be doing all those things if you're worried about a patient. You should approach the patient, greet them, feel the radial pulse, watch their chest rise and fall, and see how they respond neurologically. And then you can know they're really sick, or we have some time.
Okay, that was great. That was great.
Quick.
That's Sarah's ABCs. And I love, we got the extra bonus with the main thing you're looking for clinically is signs and symptoms of reduced cardiac output. Now, from the heart of nursing, as you call it, what do you think is the most important quality, skill, trait to cultivate as a nurse?
I think it's the ability to look past just the task of nursing and see the human soul that you're caring for. I think it's very easy to get distracted and overwhelmed even by all the tasks. Got to draw the blood, got to document it, got to repeat the blood pressure, got to go send the urine off. Like, there's so many tasks in nursing. But if we can try to look through that and not get distracted by all that task overwhelm and see the human soul, I think that's what's going to make us better nurses. It also is what's going to keep us at the bedside and not burn out, because it can be the task can be very exhausting and weigh very heavily on, especially if you feel like you're just a cog in the system,
Yeah.
But if you feel like, okay, I am sending this blood work off to help this human soul figure out what's wrong with them. I'm gonna document this, blood pressure, so we can watch the trend and make sure that they are getting better, not getting worse. Like if you relate everything back to the human soul you're caring for and the opportunity that is, I think that's what makes us better as nurses. It also makes us enjoy the role of the nurse for a longer run.
Oh
It's more
man,
sustainable in that way.
I'm so glad that's where you went. I totally agree. I think like this whole nurse burnout thing is not because of this. I mean, yes, short staffing contributes to it, and
Oh, for
overwork
sure.
and what underpay, whatever you want to say, but those are all extrinsic things. I think we've allowed, what makes you bulletproof to burnout is when you have purpose and meaning in what you're doing. Like anybody who's been highly engaged in something they love to do can do it for 12 hours and be more energized when they're done than, when you're operating from your overflow. And I think we've allowed, with all the redundancies and the charting and the da da da, and the short staff, we've allowed the meaning and purpose of our vocation to be taken from us. And if we can find ways, even as individual professionals, by what things you just said, remembering the human soul part of it, you're taking care of another human being. It is a sacred act. It is not just a profession, it is a vocation. And the more, even in those little moments, to remember, I think that makes us bulletproof to burnout, even, or at least even, it's burnout and meaning and purpose are incompatible.
Yeah.
What do you, feedback? What do you think about that? That's kind of my
Yeah,
hypothesis.
I totally agree. I mean, I've heard a lot of theories as to why nurses are leaving the profession in droves. And I do think that staffing is a huge part of it.
Mm-hmm.
But it's not just because like, oh, we don't want to work so hard. No, it's that I don't have the time and opportunity to connect with human souls like I thought I was going to as a nurse because of all the tasks I'm expected to perform. So it's not that like the staffing is the contributor because of the human factor. And I feel that too. And so I definitely don't want to say like, oh, you just got to like suck it up and take care of 8 patients. Like, no, like we need to stand up and say this is not okay. But I think the way to like get through it whenever it feels overwhelming is just to make sure you're still connecting with patients. So like recently, whenever Hurricane Milton hit Tampa, I volunteered to go down there for a week and help out like in the aftermath of the storm. And I have never worked so hard. That ER was busting at the seams. I had 6 ER patients. I've never cared for 6 ER patients at a time, and they were sick. Like I had like stroke alerts and DKA and like patients going into arrhythmias. Like it was not just like, like fast track type patients. They were sick people. I couldn't tell you their names. Like it was so crazy to have that many patients with that many emergencies at one time. And I felt the sense of like, oh my gosh, there's too many tasks. I can't get them all done. I know that feeling. But I was like, no, I came here to make an impact. So, all right, my charting is going to be subpar, whatever. The labs might not get sent right away, but this patient, I'm going to connect with them. I'm going to hear these people's stories. I'm going to make an impact in their life because they are facing not just their physical illness, but their house was just flooded. They have nothing to go home to. Like I want to be with these humans, even if that means other areas are going to not be my best performance, I'm definitely type A and I've always wanted to make straight A's and do documentation perfectly. But I'll tell you right now, my documentation was not stellar that week, but my patient care was really amazing. I took the time to connect with every single patient. And when I walk away from that experience, yes, I got my butt hit. I was so tired. I'm like, I'm too old for this 12-hour shifts in a row at 40 years old. Wow. And it was like really crazy ER. But I walked away feeling so full of life that I got to be with people, during that such a heavy time in their life. Their whole town was just, hit by a hurricane. So yes, I know what it feels like to be overwhelmed by the task. I'm not downplaying that experience of like short staffing. But I also know nursing can still be rewarding, even if you feel like you're spread thin, as long as you're finding ways to still fill your cup so that when you show up the next day to your crazy shift with your rough staffing, you still have something to pour out. I think we as nurses tend to like give and give and give and pour out and pour out and pour out until we just, we're scraping the bottom of the barrel to like show up at work and still have something to give. So yes, give your heart to these patients, to your coworkers. But when you get home, find a way to fill up. Take care of yourself so that you're not running on empty.
I love that. If we could clone you and just make, like lots of Sarahs that just that message would bring more people. The way you teach and the way you take care of your team. I've listened to a number of your podcasts. The way you take care of your team, the way you admire nurses, the way you love to teach, and in such a unique way, you really illustrate what you mean, what you're thinking, what you're looking for, and the way you present your case studies, and then, bring the pathophysiology and the critical thinking into the illustration. And it's just, I'm so excited for people on the RNegade platform to be able to listen to you, which they like to do anyway, and then also get CE credit. It's going to be great. And I can't wait to see how the Sarah Lorenzini empire expands from the closet. How can people get a hold of you if they want to be? I'm going to do the Rapid Response Academy. I think. Yeah. Do I have to be? Do I have to be a rapid response nurse to join it?
Oh no, there's only like 5 or 6 rapid response nurses that are part of it. There's med-surg nurses, oncology nurses, pediatric nurses, bunch of ER nurses, ICU nurses, like all of the above. So no, you do not have to be any particular type of nurse. I would say you might be a little over the head of a nurse who's like never been anywhere and only worked in like a clinic. There's a lot of like inpatient acute care stuff that we talk about. But no, you would fit right in, Karen. You would absolutely love it. We have a blast.
I think it's like a good way to like hit like, those that double Dutch jump ropey thing. Like I've been thinking for like 2 years, I got to get my hands on some person. Like I need to touch people and be at the bedside again. And things keep happening, keeps me busy. But I think that would be a good way to like jump in there fun. To gear up my mind. I mean,
if you imagine the type of nurses who are willing to like spend their off time learning more, that's who's in Rapid Response Academy. The ones who like the ones who want to like level up their game and be the best and connect with other great nurses. Like I just adore all of the nurses in Rapid Response Academy. They're such cool people, like they're very like-minded that want to like do this thing well and like really like master this whole nursing thing. So yeah,
sounds like sitting at the cool kids table, Sarah.
Something like that. Yeah. So it's called Rapid Response Academy. You can find it on my website, which is rapidresponseandrescue.com. I spend a lot of times for our social media on Instagram. I don't really do TikTok. You're welcome to find my TikTok, but I haven't posted there in like a year and a half. But on Instagram, I am the Rapid Response RN, not because I'm the only one, because when I tried to make an Instagram account, Rapid Response RN was already taken. So I was like, what else can I add to it? So I'm like, I'll be the Rapid Response RN. You can find me there. And then my podcast, like you said, is called Rapid Response RN because I tell stories from the Rapid Response RN nurse's perspective.
Yeah. And so what we've done at RNegade is a lot of Sarah's Rapid Response podcasts are less than, it has to be 50 minutes. So we have bundled them into series. So there's like an ARDS series, there's a vascular series, and it's so cool. So you get these bite-size, stories and pathophys and clinical and critical thinking and, what to do, like the way, what Sarah's doing, Sarah, and we package them into courses that are between 1 and 2.5 CEs so far. I think we have one that's 2.5 CEs. And it's just like, you don't even realize you're learning because it's like you kind of on the edge of your seat, and you got the music and the guests occasionally, but highly recommend go watch or go get your CEs for listening to Sarah's podcasts that many nurses have given her feedback have saved their patients' lives because they were able to recognize something that they otherwise would not have. So thank you for your time today, Sarah. We're so excited to have you.
Karen, I could talk to you for hours.
I know. Well, we didn't even
we have to put a cap on this.
Yeah. We got to put a cap on it. You've got like all the things that you already do. So thanks. Actually, we went over a little bit. So thanks for giving me some more time with you.
Of course.
And we will be in touch.
Thanks, Karen. All right. Have a
Bye,
good one.
Renegades.